This module will review telehealth coding and documentation adapting in crisis. On the agenda, we will talk about the definitions of telehealth versus telemedicine, types of telehealth services, telehealth or telemedicine platforms, documentation and coding. We'll take a close look at virtual visits, telephone visits. I'll touch briefly on attestation requirements for documentation. First, let's talk about telehealth versus telemedicine. Telehealth is defined as a collection of technological tools that healthcare professionals can use to monitor, treat, and inform patients and others. Telemedicine consists of virtual E&M visits with a healthcare professional that use video and audio in real time in place of a face-to-face visit. So really, what is the difference between telehealth and telemedicine? It's just slight. Telehealth are the tools that we use to render telemedicine. The different types of telehealth consist of synchronous telehealth, and synchronous telehealth is defined as live video conferencing with both audio and visual capabilities. Synchronous telehealth is typically done via a HIPAA-compliant platform, such as your EMR. So for example, in Epic, our HIPAA-compliant platform for virtual health or telehealth are our virtual MyChart visits. However, during the COVID-19 emergency, the Office of Inspector General, or OIG, who maintains the HIPAA security and privacy regulations, has stated that they will allow platforms such as FaceTime and Skype to be used to see patients via virtual visits. We don't know if this is going to continue moving forward. Chances are that most likely once COVID dies down, we will have to go back to the HIPAA compliant platform, as that's what the regulations state. But right now, just to allow the flexibility and the ability for all people to utilize electronic tools, it is okay to use things such as FaceTime and Skype for synchronous virtual visits. Asynchronous visits are defined as patient information being transmitted through electronic means to a provider, i.e. store and forward types of technologies. So these are going to be things like your e-visits or, again, in Epic, a MyChart message back and forth between the patient and the provider. Remote patient monitoring are results transferred electronically to a provider that then reviews, monitors, and takes action based on those results. We'll take a closer look at this later on in the presentation, and I'll explain some more examples of what remote patient monitoring entails. And then there are other types of telehealth services that may be utilized and or leveraged during times such as this COVID-19 pandemic. Those include interprofessional consultations, virtual check-ins, and e-visits. And again, we'll take a deeper dive on all of those a little further along in this module. So virtual visits are defined as synchronous audio and visual visits conducted via a HIPAA-compliant platform. And remember, the HIPAA-compliant platform rule is a little bit relaxed right now due to the pandemic. The key thing with virtual visits is that both the audio and the visual components must be met in order for it to be defined as a virtual visit. If the visual component cannot be met, as we've seen is a struggle for a lot of our elderly Medicare patients, then we only have an audio visit and we would look to billing those with a telephone encounter code. And again, we'll take a look at those a little further along in this module. Virtual visits are typically coded and billed the same as if the patient had been seen face-to-face and in person. These are reported with your traditional E&M codes. So, for example, your 99201 through 99205 for new patient visits and 99211 through 99215 for your established patient visits. Typically, a virtual visit is going to consist of a distance site location where the patient is located and the site where the physician is located. Keep in mind, the distance site under traditional telehealth is defined as a facility setting, such as a rural hospital. However, during the time of crisis, such as COVID-19, CMS has decided to lift the distance site facility restriction, and the distance site can now be defined as the patient's home. One of the things that we are unsure of is if this distance site requirement will remain lifted after COVID-19 dies down, or if CMS is going to go back to requiring the distance site facility such as a rural hospital. Only time will tell on what's going to happen with that. Traditionally, virtual visits are usually limited to established patients only. Again, however, during the COVID-19 crisis, this established patient requirement has been relaxed and we can do virtual visits to establish a relationship with a new patient as well. Again, is this something that's going to change once COVID-19 dies down? We don't know. So we'll just have to continue to monitor, and it's a wait and see at this point. And usually virtual visits are limited to office outpatient types of services. However, again, during COVID-19, to help limit exposure to COVID-19 positive patients, in addition to limiting the use of PPE, CMS has added most inpatient services to the allowed telemedicine platforms. So what we're doing in our facility for inpatients is providing virtual visits utilizing iPads. We might provide a virtual visit utilizing the patient's phone. So if they have an iPhone, we might do a FaceTime visit. If they don't have an iPhone, we might get Facebook Messenger set up on their Android and do visits through Facebook Messenger. Or we might download Skype, those types of things. So we're trying to utilize different technological tools to provide virtual visits to our patients in the inpatient setting. The other thing too is that if a patient is inpatient, a virtual visit, the physician for a virtual visit may be located in their office on the same campus or same site as the patient's inpatient location, or the physician may be sitting at the nurse's station providing the virtual visit from the nurse's station as well. Again, we're looking into different modes and methodologies to limit exposure to PPE and limit exposure to the patients that are COVID positive. So what are the documentation and coding requirements for virtual visits? And I have a couple of tips to keep in mind when documenting and selecting your level of service or evaluation and management code for billing. For H&Ps and consults, in addition to new patient visits, virtual visits do still require 3 out of the 3 key requirements of history, exam, and medical decision making to support the final level of service billed. You're probably going to wonder, what do you do as far as the physical exam? Keep in mind there are several body systems, when appropriate, that can be examined by simply observing the patient through the virtual platform. And we're going to take a closer look at this on the next slide. For subsequent daily visits or established patient visits in the office, only 2 of the 3 key components are required to support billing or your overall level of service selection. In most instances, you will not have a physical exam performed and documented. You would then select your LOS or your evaluation and management code based on the documentation of the history and the assessment and plan. And of course, time-based billing is always appropriate in a virtual environment. To bill based on time, you would document and report your level of service based on this statement or the greater than 50% rule that says something along the lines of, I spent 25 minutes with the patient today. More than half this time was spent counseling and coordinating care as outlined. So what about that physical exam element? There are several body systems that you can inspect or assess through direct observation. Some examples are as follows. The general appearance of the patient. Are they in distress? Are they not in distress? Do they look disheveled? Again, you can document the overall general appearance of the patient through visualization. Vitals. You can have the patient take weight and temperature from home. You can even have them record blood pressure if they have a home blood pressure device. When you do this, though, make sure your documentation clearly states that these are patient-reported vitals in your note, and all will be well. You can also examine the eyes just by visually looking at the patient. Do they have, are they non-icteric? Are the conjunctiva clear? Those types of things. Respiratory effort, mood and behavior, thought process, cranial nerves are also examples of elements that can be examined visually. Gait and station. You can have the patient walk back and forth in front of the camera and assess their gait. For skin tone, color, lesions, if the patient's calling in with a chief complaint of a rash, you can always have them hold up that body area, let's say it's on their arm, have them hold up their arm to the camera and you can visually inspect the rash through the camera. And then edema, nail beds, ENT, you can do external inspection of face, ears, nose, and throat. Again, all good examples of elements that you can visually examine as a part of that physical exam of the patient. And then, as always, you really only want to examine and document the elements that are appropriate based on the chief complaint or the reason for visit with the patient for that day. Telehealth modifiers. I do want to touch on the different telehealth modifiers that may be reported. If you recall, in the CPT section of the coding classifications module, I introduced you to different modifiers that we append to services billed. These modifiers are going to tell the insurance company the type of telehealth, was it synchronous or asynchronous, that was provided to the patient. And there are 3 potential modifiers. The first modifier and the most common modifier that we report is modifier 95. And this modifier states, synchronous telemedicine service rendered via a real-time interactive audio and visual telecommunication system. There's also modifier GT that states via interactive audio and visual telecommunication systems. You're probably asking me what's the difference between modifier 95 and modifier GT? And honestly, I don't know the answer to that. Modifier 95 is a newer modifier that came out within the past 2 years and is really the most common modifier that we report for synchronous audio and visual telecommunication or telehealth services. So I'm not sure what the difference really is between modifier 95 and GT. If we're not sure which modifier the payer wants us to report, I would default and report modifier 95. And then finally, there's modifier GQ, which indicates via asynchronous telecommunication systems. And honestly, we don't use modifier GQ all that often because the codes that we would report for asynchronous systems actually have within the CPT definition, it's pretty inherent in the CPT definition that it was an asynchronous system. So if we're going to use online digital evaluation and management codes for e-visits, it's pretty clear in the description of the CPT code that the communication was asynchronous with the patient. So we really are not using modifier GQ all that much. One of the things I do want to mention about the modifiers is that not all payers are following the same rules as it relates to which modifier they want you to report on telehealth services. Again, most payers will apply modifier 95, but not all payers are following the same guidelines. So because of that, for example, my team and I spend a lot of time every day looking at the payer guidelines and seeing if they've made any updates to the telehealth requirements, and especially as it relates to the COVID-19 pandemic. As the payers are making updates to the required modifiers, we are putting rules in place in the system to append the appropriate modifier based on the payer guidelines. So hopefully you have somebody at your organization that can monitor that for you and apply these modifiers appropriately. If not, make sure you review the payer guidelines frequently. So next, let's move to telephone encounters. Telephone encounters, or telephone E&M codes, are defined by CPT and the AMA as time-based codes. This means that the typical documentation of history, exam, and medical decision-making are not the main components to use when selecting the telephone level of service. The documentation for telephone encounters must include, at a minimum, the following elements: the reason for call or the chief complaint, a brief problem-focused history of the chief complaint, an assessment and plan and/or medical guidance provided to the patient, and the total time spent on the call with the patient. A modifier is not required when reporting the telephone CPT codes. Again, the CPT code description is inherent and defines these as a telemedicine service that is asynchronous. That is synchronous, so we do not need to report a modifier on the telephone evaluation and management codes. The codes that we would report for telephone encounters are 99441, which is defined as telephone evaluation and management service by a physician or other qualified healthcare professional who may report evaluation and management services provided to an established patient, parent, or guardian, not originating from a related E&M service provided within the previous 7 days, nor leading to an E&M service or procedure within the next 24 hours or soonest available appointment, and that code is reported for 5 to 10 minutes of medical discussion. 99442 is reported for 11 to 20 minutes of medical discussion, and 99443 is reported for 21 to 30 minutes of medical discussion. Anything beyond 30 minutes of medical discussion is still reported with 99443. A couple of things I want to point out about the telephone codes. These codes traditionally have not been recognized by CMS or private payers. However, on March 1st of 2020, CMS decided to go ahead and allow the recognition of the telephone encounters, and they added these codes to the fee schedule. So they are now paying and reimbursing for the telephone encounter services. There are several payers that are following Medicare guidelines and allowing telephone E&M codes, but then there are a few payers such as Medicare and United Healthcare that are actually instructing us at this time not to report the telephone encounters, and if we do an audio-only encounter with a patient, to go ahead and report those audio-only encounters with our standard evaluation and management codes. So as you can see, not all payers are following the same rules, so yet another reason why it is extremely important to stay up to date on what the payer requirements and guidelines are as it relates to telehealth services. Another thing I'd like to point out about the telephone encounter codes is that even though the code is defined as an established patient-only code, right now during COVID-19, we are also being allowed to utilize the telephone codes for new patient visits in addition to established patient visits. This most likely will go back to being limited to established patient visits once COVID-19 has settle down. However, CPT updates annually in January, so there is always the possibility that CPT will update the definition of the telephone encounters to allow for both established and new patient visits. Everything that's happening in current state is going to most likely drastically change how we look at a lot of these codes and the billing requirements into the future. We're moving into a new normal. The other thing I want to mention about these codes is that you cannot have a related E&M service within the previous 7 days or lead to an E&M service within the next 24 hours or soonest available appointment. If you had an E&M service 7 days prior, or the telephone encounter leads to an E&M service or a procedure the next day and it is related, then we cannot bill the telephone encounter codes as they are considered bundled or inclusive to the E&M service that either took place or results from the call. The other thing, and the final thing I'll say about these codes, is that there is not a definition of what the soonest available appointment is. Is it the next day? Is it within the next week? We really don't know what that means. So look to your organization to create a definition or rule for that. So let's move on to the digital online evaluation and management services. This is actually a new code set that went into place on January 1st of 2020. And the nice thing about these codes is that CMS has recognized these codes from their inception, meaning that CMS will actually allow and reimburse for these services, which is a step forward in the right direction for CMS because typically they don't like to allow or pay for digital or telehealth types of services. So they're actually starting to become more familiar with and more comfortable with the telehealth platforms. And I think that moving into the future, they're going to have to become even more comfortable with the telehealth platforms. So these are patient-initiated services with a physician or other qualified healthcare professional via a HIPAA secure platform such as an EHR portal, secure email, or other digital applications. In Epic, for example, you might utilize these through the Epic MyChart messaging portal. And we have actually established an e-visit system in my organization that we utilize for same-day e-visit types of services. And we've really limited at this point to certain acute illnesses and injuries that we will provide services via the e-visit platform. However, I can see this being extended out in the future. These do require an evaluation, assessment, and management of the patient, and they are not to be used for communication of test results, scheduling of appointments, or other communication that does not include an evaluation and management service. And one thing I do want to mention is this final bullet also holds true for your telephone encounters. For telephone encounters, you should not report those telephone codes for the communication of test results, scheduling of an appointment, or any other communication that does not include an evaluation and management service, which is typically an assessment and plan, some type of medically necessary medical decision making that is provided to the patient. There are 3 CPT codes that we can report for digital online evaluation and management services. They include 99421, which is defined as online digital evaluation and management service for an established patient for up to 7 days cumulative time during the 7 days, and this is 5 to 10 minutes. 99422 is 11 to 20 minutes, and 99423 is 21 minutes or more. So let's break this down. If you see here, these are limited to established patients only. And that holds true right now, even during the COVID-19 pandemic. I have not seen that these have been updated to be allowed for new patient visits. They might be, but right now in my organization, we are limiting these still to established patients only. These are used to report cumulative time during a 7-day stretch. So you might have a online communication back and forth with a patient, and sometimes we're not always quick to answer right away. Us as physicians physicians should be responding to their patients within a 24-hour time frame, but the patient may take a little bit longer to respond. So what you want to make sure you do is to keep track of all of the time that you've spent during that 7-day time frame or during that time frame that it takes to come to a resolution with the patient, and then you will bill for all of that time. And of course, you do not want to submit these charges until you do come to that final resolution with the patient. Once that resolution has been hit, then you will go ahead and submit your CPT code based on the final note with the final time documented in that note. Documentation for your online E&M service should include at a minimum the following elements: the total cumulative time spent over the 7-day period. You might include a time statement in each conversation or each message you send to the patient, or you might just have your final time statement in the last message sent to the patient. However that works for you, just make sure you have that total time documented in the note. Of course, the reason for the communication, which again is going to be like your chief complaint, a problem-focused history of the chief complaint, which is most likely going to be provided by the patient. However, you may summarize it. And then your assessment and plan and/or medical decision-making or medical advice that you have rendered to the patient. So outside of your virtual visits, your telephone encounters, and your online digital visits, there are some additional opportunities as it relates to telehealth services. First of all, we have these virtual check-in codes that are specific to Medicare. However, some commercial payers may allow and pay for these codes as well. The first code is G2012, which is defined as a quick 5-minute patient check-in. And then there's G2010, which is for image and/or video review. So maybe the patient sends you a snapshot of a rash that they have, or sends you a snapshot of their respiratory effort, or something along those, or a video of their respiratory effort, something along those lines. If you have certain things documented, you can go ahead and bill for these services. Quite honestly, these are not things that we are billing for in my current institution because there are some additional patient consents and documentation workflows that need to be in place in order to support billing for these. I think the biggest challenge with the virtual check-ins and then also down below with the interprofessional consultations is that the patient consent for the service and billing has to be documented within the record. And really most challenging, especially on these virtual check-ins, is that each time the patient initiates one of these check-ins, you have to have a financial consent to bill. And the patient has to understand and consent to the acknowledgement that they understand that they could be responsible for out-of-pocket costs on these services. Now, in my current institution, we only obtain a patient financial consent on an annual basis. So how do you go about obtaining patient financial consent each time they want to do a quick check-in with you as the provider or send you an image or a video for review? That's something that we're still working through. If you do not have that patient consent each time on file, then you should not be billing for these services. So again, that is something that you'll have to operationalize and figure out within your practice. The other thing I just want to mention about the G2012, the quick 5-minute patient check-in. Realistically, how often are you going to have a quick 5-minute check-in with a Medicare patient? Probably not very often. Most times these patients require more time, more thought, more resources. So for a quick 5-minute check-in with a patient, that has to be patient initiated, that you have to get consent for each time, consent for billing each time before you provide the service. Honestly, a lot of that work effort is probably going to cost you more than what you would get paid from Medicare. So just keep some of those things in mind when you think about billing and putting these workflows into practice. Another opportunity revolves around remote patient monitoring, and the CPT code range here is 99453 through 99457. These include things such as patient-reported blood pressure monitoring, patient-reported physiological parameters such as weight, blood pressure, pulse ox, respiratory flow rate, etc. If you are going to document and bill for these, there are certain requirements that have to be met in your system. Some of these codes require that the patient report blood pressure readings over a certain number of days, 2 times a day, things like that. So how are you going to capture that information in the system? Is the patient going to send you a log and then are you going to document that into a flow sheet? Is the patient going to send you a log that you're going to scan and upload into the system? What are the different documentation requirements that you need to support billing for these services? And then does the patient understand that they're going to be responsible for any coinsurance and deductibles that insurance may assess to them as out-of-pocket patient costs? It's becoming more common for us to monitor things remotely, but patients don't understand that if they don't see you in person, face-to-face in person, that they're going to get billed for that. So patients need to be educated that there might be out-of-pocket costs assessed with these remote monitoring services. And that's something that you truly need to keep in mind, is making sure that your patients understand that. And I think that's one of the biggest struggles that we have today, is patients don't understand that just because they weren't seen physically on site or face-to-face with the provider doesn't mean that they're not going to be billed for it. Today, we don't bill our patients a lot for things like that, and now we're going to start doing that moving into the future. So again, patient education and understanding is key to this. Otherwise, you might have some patient dissatisfaction or customer service issues. So keep that in mind. Another service that we're looking at is interprofessional consultations, and these are newer within the last 2 years as well. And the CPT code range here is 99446 through 99452. And what does this mean? This actually opens up the opportunity for, let's say, for example, we might have an inpatient hospital program at one of our rural hospital settings, but we don't have certain specialists on board to be able to provide day-to-day care or coverage or support for patients that have chronic conditions. Let's just use diabetes, for example. So we may not have an endocrinologist on staff at that hospital. Our hospitalists are great, but this patient's a little bit tricky, and this patient requires a little more expertise, if you will, for their diabetes management because their blood sugars are, let's just say, completely out of control. So the hospitalist might say to the patient, I have an endocrinologist colleague that's not located on site here, and I would like to reach out to them to take a look at your medical records and consult and provide some advice to me on the best way to treat your diabetes. Are you okay with that? Do you provide me consent to reach out for this consultation? The patient says yes. The hospitalist is required to document that verbal conversation with the patient and that patient's verbal consent for that interprofessional consultation. That hospitalist then can submit a request for a consultation over to the endocrinologist who's located at a different facility. Of course, these are most likely going to be integrated facilities with integrated electronic health records. So the endocrinologist could then pull up the patient's chart in, let's just say, for example, Epic, review that patient's chart, and then make a recommendation back to the hospitalist on how to best treat that patient's diabetes. This is all done without that endocrinologist ever having to see the patient. The key for this to work, again, is that the patient knows that that endocrinologist who is off-site is going to review their charts and provide a consultation back to that hospitalist that is managing that patient in person. How do we get that consent? How do we document that consent? That's what we're looking at right now. So patient consent is key for interprofessional consultations to be billable and to take place. Another thing with the interprofessional consultations is they're only billable once every 7 days. So even though the endocrinologist is providing that interprofessional consultation, they can only bill it the first day and then once every 7 days. So even though they might be tracking that patient every day, it's only billable, again, once every 7 days. So there are some limitations on how we can bill for these services. But it is an option that's out there, and it's something that I did want to share with everybody, because if you are going into a rural healthcare setting, this is something that you might definitely want to think about and take advantage of. So, how have we adapted in the time of crisis? COVID-19 has created an opening for telehealth services to potentially become the new normal. Prior to COVID-19, CMS mandated the distance site requirement for providing telehealth. So remember, that distance site requirement has always been that the patient has to be located at a distant facility type of setting, whether it's in a hospital inpatient setting, outpatient setting, but some type of facility type setting. With COVID-19, that distance site requirement was lifted, and the distance site can now be defined as the patient home. What is going to happen when COVID-19 starts to settle down and we start going back to our normal? Does that normal even exist anymore? I don't think so. There's going to have to be a new definition of normal, and I think that CMS is going to have to eliminate that distance site requirement moving forward. Will they, though? We don't know. That remains to be seen or remains to be heard, so we just have to wait and see what CMS is going to do. Commercial payers had also restricted coverage and had followed Medicare's lead in the past. But now, even in the times of COVID-19, the commercial payers continue to follow Medicare's lead, and they have become more relaxed and allowed for virtual telehealth services. Are the commercial payers going to continue to be relaxed as we move into the future? I think they're going to have to. But we have seen that quick action from both the government and private sectors, and they very quickly opened up coverage for telehealth services throughout the COVID-19 pandemic. But again, the question still remains, how will this change after the pandemic? Are we going to continue with virtual visits? It's something that physician practices are going to want to decide. And they're going to want to decide it based on, are the payer guidelines going to remain as is, where the patient can be at home and we provide a virtual visit to the patient who's located at home? Or are the payers going to revert back to the distance site requirement of a facility setting? If the payers still allow the distant site to be the patient home, I think it would be very feasible for physician practices to continue to allow for virtual visits. The other question that we have to keep in mind is, are virtual visits going to be allowed for established patients only? Are we going to revert back to that established patient only requirement, or will virtual visits continue to be allowed for new patients? That one I'm kind of leaning towards that the payers are going to revert back to the established patient requirement. And I also feel that most physicians will still want to see new patients and consultations in person, because that's the only way you can truly best examine a patient is if they are there in person. And you really want to see a new patient and examine them thoroughly the first time, I would imagine. Of course, it's going to be physician preference. But because of that, I do believe that virtual visits will go back to being limited to established patients. We'll see. But I think it's also going to be physician and patient preference on the virtual visit platform. I'll just use myself for example. During the COVID-19 crisis, I did have to do an audio-only telephone encounter with a physician. I didn't really care for it as the patient. So I can't see myself opening up to virtual visits and telephone encounters in the future. I like to have that personal interaction with a physician. But you will have patients, probably your younger patient population, that don't really care if they have that personal interaction with a physician or not, and will just want to do what's convenient for them. So they will really, really prefer and continue to prefer virtual visits and telephone encounters. But it's also physician preference. I do know that in our organization, 90% of our physicians, both primary care and specialty care physicians, have stated that they would love to continue with virtual visits moving into the future. So I think that we will continue to offer virtual visits in some way, shape, or form, whether they be self-pay only services or we can continue to bill to insurance. Time will tell, and we will adapt as the payers adapt, and we will continue to try to be innovative with our virtual offerings, and again, leave it somewhat up to physician preference, and of course leave it up to patient preference as well. So we'll see what the future holds, and it'll be interesting to see how 2020 continues to play out and how the landscape of telehealth services changes throughout the rest of this year. So with that being said, if you do have any questions that came up during this presentation, please make sure you jot those down. And again, you will be able to email those to me, or when we have our synchronous class, you'll be able to ask me those questions during that class. But I do hope that you enjoyed learning about the telehealth platforms that are out there, and I hope this was enlightening and kind of opened your eyes to how we've quickly adapted in a time of crisis. And it's also amazing to see how insurance companies can adapt so quickly in a time of crisis, and it makes you question why it took them so long to get to where they are. Thank you.